Let's now talk about confirming and dating pregnancy. So here's a case. A 19-year-old presents to the emergency room with complaint of nausea, vomiting, and right lower quadrant pain. She states the pain has become increasingly worse over the last 12 hours. She has no medical problems, no surgical history. She's never been pregnant. Her last menstrual period was 10 weeks ago, but she reports cycles are irregular. On physical exam, her vital signs are stable and she is afebrile. She is tender in the right lower quadrant on abdominal exam. On pelvic exam, there is no cervical motion tenderness, but she has fullness and tenderness in the right lower quadrant. What is the next best step in her management? A, ultrasound, B, urinary analysis, C, urine pregnancy test, or D, serum pregnancy test? Let's go through the lecture to figure out what the answer is. So there are several ways that we can confirm pregnancy and we can establish gestational age. We're going to talk about each of these and talk about the risks and the benefits and why one test is better than the other. So first of all, let's talk about last menstrual period. If we know a patient's last menstrual period and cycles are regular, we can determine the gestational age. And we use something called Nagel's rule. So what we do is we take the last menstrual period, subtract 3 months, and we add 7 days. So if a patient tells us her last menstrual period is April 1st, we subtract 3 months, giving us January, add 7 days, giving us the 8th, and we would know that her due date is January the 8th. Okay, again, this is based on an accurate last menstrual period. We can also confirm pregnancy through a urine pregnancy test. Now, the urine pregnancy test is a qualitative test. That means that it either tells us the patient is pregnant or the patient is not pregnant. So there's some benefits to that in that we can tell if a patient is pregnant, such as in our case that we discussed when we're trying to figure out what may be in our differential diagnosis, but this does not tell us how far along the pregnancy is. Next is a serum pregnancy test. Now this is a quantitative test. So this tells us exactly how much beta-HCG is in the blood. Different than the urine pregnancy test, if we remember, that one is qualitative, so it just says the patient is pregnant or the patient is not pregnant. With that serum test, because we can determine the amount of HCG, we can use that to help us with our ultrasound to determine if we should or should not see something in the uterus to help establish the gestational age. When the beta-HCG is at least 2,000, we should see something in the uterus on transvaginal ultrasound. When the beta-HCG is 6,000, we should be able to see something in the uterus on abdominal ultrasound. Speaking of ultrasound, this is the most accurate way to determine the gestational age. We expect with ultrasound in the first trimester that when we measure the fetus from the crown rump length, that it will be within 1 week of the last menstrual period. We'll talk about that in a little bit more detail as we go throughout this slide. This is a high yield amount of information, remembering how we confirm pregnancy and establish the gestational age using these 4 tests. So back to our patient. She's a 19-year-old presenting to the emergency room, again complaining of nausea, vomiting, right lower quadrant pain, and last menstrual period was about 10 weeks ago, and on exam we feel some fullness on the right. Now, when we again think about those options of what we should do next, what do you think the answer is? Well, the answer is D. We want to do a serum pregnancy test. Remember that with the urine pregnancy test, this is qualitative, so this just tells us if the patient is pregnant or if the patient is not pregnant. That serum pregnancy test is more important because it actually tells us what the beta-HCG is, so that when we do our ultrasound, we'll know if we should see something in the uterus or if it's too early. That helps us with our differential diagnosis. So, moving on to that ultrasound and establishing the gestational age. Again, using the ultrasound the first trimester is the most accurate. How we use it, we measure the crown rump length, so the distance from the crown of the fetus to the rump. We expect that to be within 1 week of the last menstrual period. So let me explain that in a little bit more detail. If by a patient's last menstrual period, the fetus is measuring 8 weeks and 2 days, and by our ultrasound, the measurement is 6 weeks and 5 days, we would defer to the ultrasound. Last menstrual period, again, is only accurate if it's dated, if it's a 28-day cycle and it's regular. that ultrasound is only going to tell us how far along the pregnancy is based on the date of conception. So in that case, we would go with the gestational age that the ultrasound is giving us. And let me give you another example. If the last menstrual period says the patient is 7 weeks and 2 days, and our ultrasound says she's 7 weeks and 5 days, which one will we choose? You guessed it right. We would use the last menstrual period because the last menstrual period and the ultrasound are within 1 week of each other. Now, in the second and third trimester, we can still use that for establishing gestational age, but it's not quite as accurate as when we do it in the first trimester. In the second and third trimester, we use the biparietal diameter, which is the distance between the parietal bones in the head. We use the abdominal circumference, and we use the femur length to determine the gestational age. Now, here's a little rule. In the first trimester, the ultrasound can be off by 1 week, second trimester, 2 weeks, third trimester, 3 weeks. So why the big difference? Why does it increase as the gestational age increases? Well, there are many things that start to influence the size of the fetus as we get into second and third trimester. There are fetal factors, there are maternal factors, there are placental factors. Again, as we discussed in the first trimester, the only thing that influences the gestational age is the date of conception. So let's move to another question. A 23-year-old presents to the emergency room with complaint of left lower quadrant pain. She states that the pain is a 3 out of 10. She states she's had slight vaginal bleeding, and she reports a positive pregnancy test approximately 6 weeks ago. This is her first pregnancy. She has no other medical problems or surgical history. On physical exam, vital signs are stable, and she is afebrile. On sterile speculum exam, you see slight vaginal bleeding. And then on bimanual exam, she has slight tenderness in the left lower quadrant. Lab results show that her beta-HCG is 400 milligrams per deciliter. On the transvaginal ultrasound, there is no gestational sac in the uterus, there is no free fluid in the pelvis, and the adnexa are within normal limits. So what is the next best step in her management? A, admit the patient to the hospital and prepare for surgery. B, reassure the patient that her pregnancy is normal and her pain is expected for her gestational age. C, proceed with medical management as patient most likely has an ectopic pregnancy. Or D, repeat the beta-HCG and ultrasound in 48 hours. The answer for this one is D. Remember that we don't see anything on transvaginal ultrasound in the uterus until the beta-HCG is at least 2,000. With this patient, her beta-HCG was only 400. So this may very well be a normal pregnancy. However, it may be an ectopic pregnancy. We really just don't have enough information to tell. So the correct answer is to repeat the beta-HCG in 48 hours because we do expect it to rise by 50% if this is a normal pregnancy, and then repeat the ultrasound because we may be able to see something in the uterus by that time. So just to recap, this is the high-yield information that you need to know for this lecture, confirming pregnancy and establishing gestational age. Pregnancy can be established by last menstrual period, urine or serum pregnancy test, or ultrasound. The last menstrual period is the most accurate for establishing gestational age if it's consistent with the transvaginal ultrasound. If the last menstrual period is unknown, first trimester ultrasound is the most accurate way to establish the gestational age. When the beta-HCG is greater than 2,000 milligrams per deciliter, gestational sac should be seen on ultrasound. And then remember that other little fact I told you. In the first trimester, the ultrasound should be within 1 week of the last menstrual period. In the second trimester, 2 weeks. And in the third trimester, 3 weeks. So now let's discuss routine screening in pregnancy. So here's a case. A 23-year-old G1 P0 intrauterine pregnancy at 8 weeks and 5 days presents for her initial prenatal visit. Which of the following tests would you not order as part of her routine initial prenatal labs? A, complete blood count. B, maternal serum alpha-fetoprotein. C, blood type and Rh factor. Or D, HIV status. Let's go throughout the lecture to find that answer. So, initial prenatal visits routine screening. This is actually discussed in another lecture slide, but we'll go through this briefly. First, blood type and Rh factor. We do want to know a patient's blood type and if they are Rh negative or Rh positive. Why is that? Well, if the patient is Rh negative and the baby, remember whose blood type we don't know, is Rh positive, mom can make antibodies against positive blood types And during her next pregnancy, if that baby is positive, those antibodies will go and attack that pregnancy. So we want to know that so that we can do preventive things during the pregnancy so that those antigens and antibodies don't cross. So complete blood count. We want to establish a normal hemoglobin and hematocrit for the beginning of pregnancy because we do know that physiologically, pregnant women do experience anemia. So we want to know where they're starting. So during our initial prenatal visit routine screening, there are some infections that we need to screen for. Let's talk about these in a little detail. First is rubella. Now, most women are rubella immune because they did receive vaccinations as children. However, sometimes even with the vaccines, we do not build up the immunity to rubella, and to contract rubella during pregnancy can mean some adverse outcomes for the fetus. So it is recommended we screen to determine if a patient is rubella immune or non-immune in the first trimester. Unfortunately, if they're non-immune, we're still not able to give the vaccine until after the delivery. For HIV, the CDC says that 50,000 people will be infected by HIV every year. So it is recommended that all pregnant women get screened as part of their initial prenatal visit. If they're in an area that's high risk for HIV, or if they participate in behaviors that will increase their risk of contracting HIV, it is recommended that they also get screened in the third trimester because of the effects it can have on the fetus. Moving on from there, it's recommended that all women get screened for syphilis through the RPR or VDRL in the first trimester. If they're in a high-risk area for contracting syphilis, it's recommended that they get screened in the second and third trimester as well. And for hepatitis B, because of the risk of transmission to the fetus, it is recommended that pregnant women get screened for hepatitis B at their initial prenatal visit. Now, also as part of the initial prenatal visit screening, if a patient has not had a pap smear in the last 3 years and they are over 21 years old, it is recommended they get a pap smear for their baseline labs, and as well as cultures for gonorrhea and chlamydia. Women should also be screened for hemoglobinopathies and genetic diseases. In particular, for African American women, they should be screened for sickle cell trait. For Ashkenazi Jews, they should be screened for Canavan's disease and for Tay-Sachs. And for Caucasian women, they should be screened for cystic fibrosis. So back to our question. A 23-year-old G1P0 intrauterine pregnancy at 8 weeks and 5 days presents for her initial prenatal visit. Which of the following labs would you not order as part of her routine initial prenatal labs? A, the complete blood cell count or CBC. B, maternal serum alpha fetal protein. C, the blood type and the Rh factor, or D, HIV status. The answer is B, maternal serum alpha fetal protein. This is not part of the routine screening labs. Now, let's move on for screening for Down syndrome. We're going to discuss this in great detail in another lecture, but it's important to note that while women of advanced maternal age are at increased risk for having an infant with Down syndrome, all women should be offered screening in the first trimester. So there are other routine screening tests that are done through pregnancy. One is the anatomy ultrasound. This is done between 18 weeks and 22 weeks gestation. And at this anatomy ultrasound, we look at all structures of the fetus to make sure they're within normal limits. We look at the brain, we look at the heart, the intestines, again, looking to see if there are any structural abnormalities. Screening for gestational diabetes. Now, we have a whole lecture that's devoted to gestational diabetes, but to keep with our theme and discuss about how we screen for it, this is done between 24 and 28 weeks of pregnancy. In the States, we do the 50-gram glucola test. And if a patient has a random glucose level of 140 milligrams per deciliter, they are considered to have a positive screen for gestational diabetes, and they need the confirmation test, which is a 3-hour test. In this test, they come in, get a fasting blood sugar, drink a 100-gram glucola test, and then they have a blood sugar at 1 hour, 2 hours, and 3 hours. If they have 2 values out of those 4 lab values that are abnormal, they have gestational diabetes. Now, for women that are Rh negative, again, we discussed the ill effects that can happen in a pregnancy when a patient is Rh negative and some of the preventive measures that we do. We give RhoGAM at 28 weeks to, again, help bind those antigens so those antibodies don't form against an Rh-positive fetus in the next pregnancy. So this is not a screening test, but this is something that's also recommended for pregnant women. That's the pertussis vaccination. Because there's been a resurgence of whooping cough, the CDC recommends all women get vaccinated for pertussis in the 3rd trimester, and they're able to pass some of that immunity on to the baby. Now lastly, we screen for group B beta streptococcus, or GBS, at 35 to 37 weeks. Now GBS is a bacteria that's part of the normal vaginal flora. However, if it's not treated during delivery time, especially a vaginal delivery, then the infant can contract this disease and it can lead to meningitis or pneumonia. So it's very important to know if a patient is positive for GBS so they can receive the appropriate treatment. Hi, now we're going to discuss screening for Down syndrome. So there's 3 ways that we screen for Down syndrome in pregnancy. We're going to discuss those methods and talk about why we would choose one over the other. So the first is the free fetal DNA test. Basically, we have found that there's free fetal DNA circulating in mom's blood. So mom's blood is drawn, usually after 10 weeks of gestation, and you're able to see the actual karyotype of the fetus. So you know with a 99% accuracy if the fetus has Down syndrome. You're also able to find out the sex of the baby at that time. So the next option for screening is the integrated, sequential, or contingency screening. These are all grouped the same way, but they're performed just a little bit differently, and it can be confusing. So let's go over that. So this test is performed between 11 weeks and 13 weeks and 6 days, has a detection rate of 96%. Now, the test involves performing a test called the nuchal translucency. That's an ultrasound that measures the skin fold behind the baby's neck. That is done along with blood work, PAPA, and beta-HCG. Now, the difference in the tests. So the integrated screening takes the results of that 1st trimester test, again, the nuchal translucency and those 2 hormones, PAPA and beta-HCG, and looks at the blood work in the 2nd trimester, which is essentially the quad screen, integrates them together to give a patient's risk of having a fetus with Down syndrome. Now, this is done as probability, so there is no value that's high or low or correct or incorrect because it's done as probability. Sequential screening means that you take the results of the 1st trimester, you get a result. You take the results of the 2nd trimester, get a result. And overall, you're given a result. That's a little bit different than the integrated, where with the integrated, you don't get a result until the 2nd trimester. The contingency screen is done in the 1st trimester, and if the risk of having Down syndrome is low, the 2nd trimester test is not done. Only an alpha-fetoprotein is done in the 2nd trimester to determine if there's a risk of nuchal translucency. Together, these each have a detection rate of about 95 to 96%. The 3rd test is the quad screen. This is performed between 15 weeks and 22 weeks and 6 days of gestation. Mom's blood is drawn looking for 4 different hormone levels. That's HCG, estriol, inhibin A, and alpha-fetoprotein. This has the lowest detection rate. It's 81%. And again, this is done as probability. So it looks at a mother of that ethnicity at that gestational age with those 4 hormone levels to tell the probability of the baby having Down syndrome. So you can see amongst the 3 tests, the free fetal DNA is the most accurate. However, because it is a little bit newer, it is the most expensive test of the 3. We do recommend this test for our women that are over 35 years old, as they have an increased risk for Down syndrome. The quad screen can be used if a patient enters pregnancy after 13 weeks and 6 days and is not able to get the integrated, sequential, or contingency screen. Now, these previous discussed tests are meant for screening purposes only. So if they're abnormal, then invasive testing is recommended. So what are our options for invasive testing? Well, there's 2, chorionic villi sampling and amniocentesis. So chorionic villi sampling is performed between 10 to 14 weeks of gestational age, and as you can see here in the picture, a needle is inserted into mom's belly, and there's blood that's drawn from the chorionic villi. Karyotype is performed to see if the fetus indeed has Down syndrome. The risk of this procedure is pregnancy loss, but we are able to do it at an early gestation. The next invasive test is amniocentesis. Now, with this test, in a similar manner, as you can see here in the picture, a needle is placed inside mom's belly, amniotic fluid is drawn, and again, a karyotype is performed. This test is usually done around 15 weeks gestational age, and again, it is confirmation to determine if a patient has a fetus with Down syndrome. The risks that go along with this procedure are bleeding, infection, placental abruption, and again, fetal loss. It was previously thought that with chorionic villi sampling that there was an increased risk of fetal loss compared to amniocentesis, but we now know that risk is about the same. So let's go through a study here. A 24-year-old gravida 1 para-0 female at 8 weeks and 3 days of gestation prevents for an antenatal visit. She has a sister with Down syndrome and is concerned that the baby may be at increased risk. The best non-invasive screening option for this patient is A, free fetal DNA, B, integrated screening, C, quad screen, or D, amniocentesis. Well, let's think about these options. The free fetal DNA, we've already said, has a 99% detection rate for Down syndrome. Integrated screening has about a 95%, and then quad screen has about an 81%. Amniocentesis is the most accurate because it is looking at the karyotype and it is the test for diagnosing Down syndrome, but we have to go back to the stem of our question. Amniocentesis is not a non-invasive test. So, based on our options, the answer is A, the free fetal DNA test.